Thank you very much. I have a very specific question with regard to the report. It will be overdue a year as of next month, and I believe it was requested in maybe 2012 or before that. When can we expect this report, and why don't we have it yet?
We are moved it to the top of our priority list to finalize edits and get it to the legislature. We recognize that it is overdue. I cannot give you a specific date at this time, but we are aware that it is late and that it is a concern, and we've made it a top priority.
Okay, but we will be expecting it in a month or two, or?
I just can't give specificity.
I think that clearly everyone recognizes that we need to move this very quickly at this point in time. And it isn't as though the work has been done. I think we're just in the finalization stages.
Okay. Before the May revise? Yeah, before the May revise?
We will make as we pointed out, we'll make every effort to make sure that it gets here by that time.
Very important that we have that information so that we can proceed in an informed manner for the budget. Thank you.
Thank you.
Thank you. Any comments by Department of Finance, LAO? All right. Senator Martin, public comments on this matter? All right, we will be holding this item open as well. Looking forward to the report. Thank you very much. Thank you. Our next subject is the Office of AIDS and the AIDS Drug Assistance Program, ADAP. Welcome to the presenters. Looking forward to your update. Good afternoon.
Am I live now? Yeah.
Yes.
Good afternoon, Madam Chair and members. I'm Dr. Gil Chavez. I'm Deputy Director for Infectious Diseases, and I appreciate the opportunity to be here today. First, just wanted to briefly tell you that the Office of AIDS it's a very key component of our center and does great work in trying to reduce the burden of HIV/AIDS in California, dealing with issues around prevention of new infections, as well as ensuring that people that are infected with HIV/AIDS have the necessary services to both have a productive life and as well as decrease infection rates in the community. The ADAP program is a vital link in that chain of both treatment and prevention. New information suggests that treating those infected with HIV/AIDS is one of the best things we can do for prevention. So certainly the ADAP program is a critical link in our efforts to combat and eliminate HIV/AIDS from California. So we appreciate the Senate's support and interest on this program over the years. I'm joined by my colleague, Dr. Karen Mark, who's the chief of that office, who will give you a summary of, I think we have 3 items on the agenda.
Yes.
And Ms. Nikki Dillon is the utmost expert on the ADAP program, so she's here to answer any questions that we cannot answer.
Thank you very much. Welcome. Your light needs to go on too. There you go.
Thank you.
Thank you.
Good afternoon. So as an overview of the ADAP budget, in fiscal year 13-14, the enacted budget included ADAP local assistance funding of $406.3 million with no state general fund appropriation. The revised 13-14 budget is $419 million, an increase of $12.7 million, mainly due to reduced savings estimates of reimbursement for drugs dispensed to ADAP clients who were identified as also being enrolled in the low-income health programs, or LIPs. In spite of this budget increase, the proposed budget does not contain a general fund appropriation nor any cuts to services, because ADAP will use all rebate funds available in fiscal year 13-14 due to the Federal Health Resources and Services Administration, or HRSA, requirement to spend rebate funds prior to spending federal funds. ADAP requests an increase of $46.4 million in ADAP rebate fund expenditure authority, mainly because of this federal requirement, but also because of an increase in the drug rebate percentage rate from 60 to 65%. In addition, ADAP requests an increase of $24.3 million in federal fund expenditure authority due to increased additional grant awards received and will receive $58 million of reimbursement funds from the California Department of Healthcare Services when compared with the 1314 Budget Act. Will return those reimbursement funds to DHCS. And fiscal year 14-15, the proposed funding for the budget year is $409.6 million. The decrease of $9.4 million compared with the revised current year is primarily due to savings from the Patient Protection and Affordable Care Act programs, including Medi-Cal expansion and Covered California. Changes to ADAP's budget authority when compared with the revised current year budget include an increase of $42.8 million in reimbursement funds, a decrease of $4.8 million in federal funds, and a decrease of $47.5 million in ADAP rebate fund expenditure authority. As always, we will update the numbers in the estimate as part of the May revise. There are no new major ADAP policy changes with substantial fiscal impact included in the proposed budget. There is a small increase in ADAP pharmacy benefits manager costs included, $103,000 in fiscal year 13-14 and $220,000 in fiscal year 14-15 due to programmatic changes to implement the federal HRSA requirement of 6-month ADAP client eligibility recertification. In fiscal year 14-15, the governor's budget proposes creating statutory authority that will allow the California Franchise Tax Board to share tax data with the Office of AIDS. The availability of tax data will complement our existing Ryan White Part B, including ADAP enrollment practices, as the Office of AIDS will be able to cross-match Ryan White Part B client data with tax data. We assume that the potential fiscal costs and savings impacts will be absorbable in fiscal year 14-15.
Thank you very much.
To provide an update on the transition of ADAP clients to Medi-Cal expansion and Covered California, by the end of 2013, most former ADAP clients eligible for Medi-Cal expansion had already transitioned from ADAP to the low-income health programs, and on January 1st, 2014, these clients transitioned from LIP to Medi-Cal expansion. DHCS oversaw this transition from LIP to Medi-Cal expansion, but we worked closely with DHCS and with our stakeholders on the Office of AIDS DHCS Healthcare Reform Advisory Committee to ensure the smooth transition of HIV-infected LIP clients to Medi-Cal expansion. A small number of ADAP clients will transition directly from ADAP to Medi-Cal expansion. These include ADAP clients who exceeded the LIP upper income limits in their county where they reside, or who are from counties who did not implement a LIP. In the fall of 2013, we sent a letter to all ADAP clients who are potentially eligible for either Medi-Cal expansion or Covered California with information about both programs and application instructions. We also developed a flow chart and provided training for ADAP enrollment workers outlining which ADAP clients should be referred to which programs, and we received extensive input from stakeholders on both of these documents. All new ADAP clients and ADAP clients who are coming in for their annual ADAP recertification, which happens during their birth month, are screened and directed towards the appropriate program. During ADAP enrollment and recertification visits, clients who are potentially eligible to purchase insurance through Covered California are informed verbally and in writing that they can seek premium payment assistance through the Office of AIDS Health Insurance Premium Payment Program, or OAHIP, and they can enroll or remain co-enrolled in ADAP for assistance with drug copays and deductibles for medications on the ADAP formulary. Clients are also informed that they will be responsible for medical out-of-pocket costs. Clients are also informed about the federal financial penalties for remaining uninsured and the fact that ADAP and Ryan White do not constitute insurance coverage through the ACA. These procedures are designed to be in compliance with the federal HRSA directive that we vigorously pursue enrollment in healthcare coverage for which our ADAP clients may be eligible. Based on our experience with the OA PSIP premium payment program, we estimated that 2.8% of eligible ADAP-only clients would enroll in Covered California in fiscal year 13-14, and 7.2% of eligible ADAP-only clients would enroll in fiscal year 14-15. As of February 28th, we have enrolled a total of 183 clients co-enrolled in Covered California and in our OAHIP program. We expect to continue to receive OAHIP applications for patients who enroll in a covered California health plan through April 2014 because clients must complete their enrollment paperwork through Covered California before they can co-enroll in OAHIP.
Thank you very much.
Would you like me to go on to the question about out-of-pocket medical expenses?
Can I ask a question?
Sorry.
Yes, we have a quick question, and that's actually part of the next item, so let's pause for questions. Senator Monning.
Thank you. This is perhaps for Dr. Chavez, but I'm just curious, less with these specific budget categories, just maybe an overview of how you assess the HIV/AIDS epidemic in California. What are the trends over the last 5 years, or prospectively? What do you see?
I think I'm going to defer to Dr. Mark on this one.
Thank you.
So we conduct HIV, and we're responsible for HIV surveillance within the state of California. And HIV infections are continuing in California, unfortunately. There are approximately 5,000 new HIV infections that occur in California every year. The number of new infections is decreasing very slightly, but thankfully the death rate due to HIV has decreased substantially. Because of this, the number of people living with HIV in California continues to increase every year.
And can you make an estimate? What's the universe of people diagnosed HIV-positive, HIV/AIDS living in California?
The total number of people living with HIV and AIDS in California is about 140,000.
Thank you.
Thank you very much. Thank you for the great report. We'll stop for a moment and see if there's any comments by LAO or Department of Finance on this part of the presentation. None. Any public comments on this part of the presentation? All right, we'll go on to the next part. Thank you very much.
Sure.
It's nice to have some good news about how healthcare programs are working. Thank you. Oh, yes, and on this particular item, we're going to ask the LAO to have a presentation on the WRAP for out-of-pocket medical expenses portion.
According to the agenda, the Office of AIDS, or the OA, has a number of programs to help people move into and retain comprehensive health coverage, such as the OA Health Insurance Premium Payment Program. However, it does not have a program to pay for the out-of-pocket medical expenses, such as co-pays, co-insurance, and deductibles, associated with comprehensive health coverage for eligible persons with HIV or AIDS. This proposal would require payment of out-of-pocket expenses related to medical costs for eligible individuals in the ADAP program. Currently, 15 other states have ADAP programs that pay for these out-of-pocket medical expenses.
All right, thank you very much. Does the Department of Finance have any comment at this point? All right, Office of AIDS, would you like to make your presentation? Thank you, Doctor.
So I'd like to thank the Senate staff for providing an excellent summary of our response to this proposal in today's agenda. The administration considers this approach part of a larger discussion on state-only programs and the impact on them of ACA implementation. Our response assumes the payment of medical out-of-pocket expenses would start January 1st, 2016. In order to implement this programmatic change, OA would need to develop a request for proposals and enter into a new contract with a third-party administrator to pay premiums and eligible out-of-pocket expenses for OAHIP clients. It's not clear at this time whether additional administrative costs would be incurred for this approach and whether there would be costs to other state programs and departments. We do estimate that between 25% and 33% of eligible ADAP-only clients would co-enroll in Covered California and OAHIP in the first year of implementation of this proposed policy change, compared with an estimated 7.2% of ADAP-only clients who will co-enroll in Covered California and OAHIP in fiscal year 15-16 if medical out-of-pocket costs are not covered. Given these assumptions, we project that the cost of paying medical out-of-pocket expenses in this proposal would range from $1.8 to $2.4 million in fiscal year 15-16, but would result in a net savings of $6.3 to $9.4 million in fiscal year 15-16. These estimates assume the current rebate return rate. Thus, from the Office of AIDS standpoint, this proposal would result in cost savings and result in more HIV-infected Californians having access to comprehensive health insurance coverage rather than relying on access to HIV medications through ADAP and HIV-related outpatient medical care through the Ryan White system. We don't expect to have any additional information that would lead us to a more refined cost estimate until we complete the May revision. If we are asked at that point to have an updated estimate, then we could use some data from the first covered California open enrollment period to update our estimate. ADAP special funds or rebate funds could be used to cover the cost of a third-party administrator to operationalize these changes. Also, per federal HRSA requirements, either rebate special funds or federal HRSA funds could be used to cover the cost of medical copays and deductibles, except for medical copays or deductibles that are associated with inpatient care.
Thank you very much. Senator Bonding, any comments, questions? Public comment, please.
Hi, Chair and members. Kathy Mossberg representing the San Francisco AIDS Foundation as well as the statewide HIV/AIDS Alliance. And we want to just go on record saying we support this concept. We appreciate the work from the Office of AIDS and all the work that's gone into this analysis from your staff's perspective. There's really not much to say except that the concept is exactly what has been put forward to keep people in care, to allow them to get care and stay in care. Fiscally, we've heard that hopefully this will not be a cost and actually would end up in savings. So we really do support this concept and appreciate your work on this. One last point, I want to just align myself with the colleagues that spoke before me in regards to public health reinvestments. We have supplied or provided a list of potential reinvestments that this subcommittee and others could look at as it relates to HIV and AIDS as we move forward into a better fiscal year. Understanding it's not perfect yet, but it's certainly better. And this has been a program that really at this point has no education or prevention element left. Those dollars were taken in what we saw as the downturn of the economy and the bad budget cycles. So thank you very much for your time.
Thank you very much. Good afternoon.
Good afternoon, Madam Chair, members of the committee. I'm Maureen O'Haron, representing AIDS Project Los Angeles. We're also in strong support of this proposal. It would increase medication adherence, and as Dr. Marks said, it would encourage more people to actually purchase coverage as opposed to relying on the ADAP program. We would also support, as Ms. Mossberg said, another review of a reinvestment into the public health programs, the education and prevention programs that were once part of the Office of AIDS and that were wiped out in 2008, 2009. So we'd ask that you would consider that investment as well. Thank you.
Thank you very much. All right. This item we will hold open as well. Thank you very much for your presentation. Thanks for the good work. Oh, do you have another one here? Let me turn my page. I'll catch up with you. Yes, the cross-match of ADAP data with the Franchise Tax Board. Please proceed.
Thank you. So we believe that the ability to match Ryan White data with FTB data will make the ADAP and OA HIP recertification processes more efficient. If combined with electronic searches for other third-party payers, it could eventually lead to ADAP 6-month recertifications occurring electronically rather than requiring client and enrollment worker time. OA currently verifies client income eligibility for its federal Ryan White programs through a variety of client-provided documents, which include pay stubs, supporter self-employment affidavits, bank statements, or tax returns. OA does not require tax returns to document income for Ryan White eligibility purposes because some Ryan White clients earn so little that they are not required to file tax returns and hence may not file them. If this cross-match of Ryan White client data with FTB data is approved, this policy would not change, and clients who do not file tax returns but provide other documentation showing that they earn less than $50,000 per year will remain in Ryan White programs, including ADAP. OA is planning to require tax returns for OA HIP clients who are enrolled in insurance plans purchased through Covered California starting in 2015. This is necessary because reconciliation information regarding advanced premium tax credits for insurance purchased through Covered California will be present on these tax returns. OA feels like the ability to obtain FTB data electronically through a data match rather than requiring clients to share with us paper copies of their tax returns, will substantially ease both client burden and enrollment worker burden at recertification time. Clients identified through the data match with an income above the eligibility limit will be given an opportunity to provide documentation proving that their income had decreased below the eligibility limit before being disenrolled from Ryan White programs. The primary reason for proposing this cross-match for Ryan White client data with FTB data is to make the recertification process more efficient for both clients and enrollment workers. However, the Office of AIDS also acknowledges that the current system of verifying client income for ADAP and OAHIP clients does leave open the possibility that some clients on these programs could earn more than $50,000 per year. For example, in lieu of providing tax returns, a client may provide pay stubs for only one job when, in fact, he or she has a second job that brings his or her income over the eligibility limit. Obtaining FTB data would enable OA to confirm that such a client is not actually eligible for ADAP and OAHIP. We do not believe that obtaining FTB data will lead to the disqualification of a substantial number of ADAP clients, although we have no way of knowing for sure until the cross-match is implemented. We have not estimated savings from this proposal because we have no way of estimating the number of ADAP clients who might be disqualified until the cross-match is implemented, and because we believe that the number of clients who might be disqualified would be small. If this policy is implemented, and if it does result in subsequently non-significant savings, then this could be addressed in subsequent ADAP estimate packages.
All right, thank you. I'm a big fan of cross-matching data, so there's an opportunity to not put up barriers for accessibility to programs because people keep having to find their paperwork and provide it, and obviously the cost savings and the work to continue to check that data. So, but I do want to ask how other departments use cross data and how do we ensure that we protect confidentiality? That's a very important concern, I think.
Sure. So the way that we've proposed doing this cross-match is through basically entirely electronically, so there wouldn't be individual people who would have access to the data. That protects the confidentiality of our client data, which is very important to us. We have looked at the way a number of other departments access FTB data and use FTB data. The Department of Healthcare Services, FTB provides non-wage earnings information to DHCS for Medi-Cal income eligibility verification system to identify applicants or recipients who earn interest, dividends, or other non-wage income, such as gambling income, in order to determine or verify eligibility of an individual for Medi-Cal benefits. The data are shared with counties nightly, and caseworkers are able to access the information through the IEVS menu functions online in the Medi-Cal Eligibility Data System, or MED system. The California Department of Child Support Services uses FTB data to administer the Child and Spousal Support Enforcement Program, including but not limited to locating and identifying assets of non-custodial, formerly known as absent parents, for the purposes of establishing and/or enforcing outstanding child support obligations. DCSS provides a weekly list of non-custodial parents to FTB to match against taxpayer records. FTB then provides the address and the financial information to these individuals to DCSS. The California Department of Social Services provides a list of income data for all recipients of social services to FTB to match against taxpayer records annually. FTB then provides the cross-match data to CDSS, which is then sorted and distributed to each county. Once received, the county social workers match the self-reported recipient information with the data provided by FTB. If the data provided by the client are consistent with the FTB data, no further action is necessary. If the data are inconsistent, then the recipient is instructed to provide additional information when reapplying for benefits.
Okay, thank you very much. Any questions, Senator Monning? Public comment on this item? Okay. Thank you very much. This is an item we will be holding open as well, so we can continue our discussions. And thank you very much for your presentation today.
Thank you.
Thank you very much. Next item will be the genetic disease screening program and prenatal screening fee increase. Good afternoon.
Good afternoon, Madam Chair, Senator Monning. I'm Daniel Kim, the Chief Deputy Director of Operations and also the Acting Deputy Director for the Center for Family Health. With me are Leslie Gaffney, who's the Acting Division Chief for the Genetic Disease Screening Program, and Chris Nelson, who's the Assistant Deputy Director for the Center for Family Health. Chris will be speaking on the GDSP proposal.
Thank you very much. Welcome.
Thank you. Thank you for the opportunity to provide an overview of the GDSP estimate today. There are 4 key issues in the estimate that I'll be highlighting: the lab consolidation, Medi-Cal reimbursement rates, caseload projection changes, and of course the fee increase. As described in the agenda, GDSP is consolidating from 7 to 5 laboratories and has gone out to bid for this change. The remaining 5 laboratories will still be regionally based throughout California, and there will be no change to the participation. There's no reduction in screening, and it'll be seamless and invisible to the participant. Savings will be realized through reducing the testing equipment and the related maintenance, operation, and repair expenses. DPH anticipates savings of approximately $1.7 million, but no sooner than fiscal year 15-16. There will be some one-time costs in fiscal year 14-15 associated with the movement of the equipment, but that estimate will not be finalized until the contract procurement process is complete and we know exactly which labs will be closing or opening. Regarding the Medi-Cal reimbursement rate, approximately 45% of our caseload is paid by Medi-Cal, and recent reductions to the Medi-Cal rates impacted our revenue. However, we will receive a refund from Medi-Cal later this year, and we have accounted for that refund in our fee increase calculation. In this estimate, we have updated our methodology for calculating caseload for both of our programs, the newborn screening program and the prenatal screening program. Historically, we have assumed that the newborn screening caseload is 100% of the birth estimate, but we have found that we test actually 98% of the birth estimate. In addition, we estimated that the prenatal screening caseload is 80% of the newborn caseload, but we have revised that to be 73% of the birth estimate to reflect actual trends. Overstating our caseload in the past has led to overstatement of expenditures as well as revenue, but the variance between budget and actuals is greater for revenue than for expenditures, and that has led to the need for the fee increase. The department has proposed a $45 fee increase for the prenatal screening program. We have not raised this fee in 7 years. The bottom line is that fees do not generate enough revenue to cover the costs. Even with the delays in collecting some fees, when all is said and done, there is still a shortfall every year. Beginning in fiscal year 10-11, actual revenues were 96% of expenditures, leaving a 4% shortfall. And that shortfall has grown steadily each year since then. In fiscal year 12-13, when all revenue is collected, the shortfall is approximately 12%. We have implemented changes to reduce costs and continue to look for ways that we can improve the efficiencies of our program and also better tie our costs to caseload, but we cannot fully address the shortfall with cost reductions alone. We need to ensure that program services continue to be state-of-the-art. The $45 fee increase includes 2 components: $26 to right-size fiscal year 14-15 alone and ensure a prudent reserve, and $19 to address the shortfall from prior years over the next 2.5 years. With the advancements in technology, we expect that we'll need to revisit the fee structure at that point. And again, note that the $19 to address the shortfall was calculated assuming that we will receive the Medi-Cal refund later this year. For context, we looked at prices that private labs in other states charge for just the laboratory work portion of our program, and the lowest price we found was about $400. That price would cover only the lab processing, and if the woman had a positive screen, she would need to pay more for other services such as amniocentesis or genetic counseling, which may be up to $1,000, and our fee includes all of those services. In preparing this proposal, we examined the overall pattern of past participation and the impact of fee increases in the past to ensure that we would not have a negative impact on access. We saw that the level of service was the critical factor that impacted participation, not the fee. We did not see abnormal caseload changes when we implemented fee increases in the past. Even in 2007, our last time for a fee increase, the fee increase was $57 or 54%, and we did not see any change other than the normal seasonal fluctuation that is similar to the birth. However, we did see a reduction in participation in 2008 and into 2009 when private labs began offering a service that we were not providing. Private labs were offering the new first trimester screen that, when integrated with the existing second trimester screen, gave a more accurate result. With the addition of integrated first and second trimester screening to our program, participation rose dramatically, 23% in 6 months, to levels higher than what we had before we had implemented that big fee increase. Therefore, we do not expect to see an impact on caseload due to this fee increase.
All right, thank you very much. Any comments by Department of Finance or LAO? Senator Monning?
I just had a question on you said the prenatal screening, about 73% of pregnant women are having that screening. How do you account for the roughly 1/4 who aren't? 1/4 of the population who aren't?
So it's a voluntary program. There are a portion of women who are, usually most of them over 35 years of age, who want diagnostic work, not screening. And so they choose not to participate in our program and go directly to diagnostics. And also there are women who won't do anything with the information and so choose not to have the test because they don't want to know.
Mm-hmm. Thank you. So it's a voluntary participation. Exactly. Thank you.
Thank you very much. Any public comment on this item?